Hello all. Now we'll do another scenario. So here again we have simulated an emergency room. So we have a mannequin here again, and we have a basic cardiac monitor, and we have got few drugs in the crash cart, and we have Dr. Karthiyani and again EMT Drona here to assist. So we'll go to the simulation exercise. So here we have a patient, 30-year-old male, has come with history of palpitations since last 30 minutes. So that is a history. So he has rushed into your emergency room. So the patient is in front of you.
Sir, complaints of palpitation is there. We have to take the patient to a resuscitation, a triage area.
Okay.
And we have to first go for an initial assessment, 10-second assessment. So we have to look for whether the patient is conscious and responding.
Patient is conscious and responding.
Okay, then we have to go with the primary assessment, primary survey. So we have to first look for the airway of the patient. Is the airway patent?
Airway is patent, as we discussed last time. So we will call the assessment initially done as the 10-second assessment. That is a quick assessment of the patient. We are not going into the detailed assessment. The next thing is that the primary assessment, where we called the assessment of the airway, breathing, circulation, and the disability. So as she said, the airway assessment, the airway is patent and is able to talk.
Okay. Then we will go to the breathing part. So we have to check for the bilateral chest movements if it is adequate. Connect him to a saturation monitoring and look for the saturation.
So his respiratory rate is 24 per minute and bilateral air entry is equal. Saturation is 98% on room air.
Okay. So since airway and breathing are on the normal side, we'll go with the assessment of the circulation. Okay. Since he had a complaint of palpitation also, C is very important here. We have to connect him to a cardiac monitor as well as to the we have to check for the BP.
Blood pressure. So I am connecting him to the cardiac monitor. So I am switching on the machine. So switching on the machine again. Red, yellow and green we have connected. So the normal connection. So this is the rhythm that you are getting in, and you are seeing here 217 as the heart rate. So it is on the higher side. He has come with palpitation. So there is a problem with C, and blood pressure is 130/80.
Okay, so here the issue is currently with the heart rate. It is like 217. So he is having a tachyarrhythmia since the heart rate is more than 150, and he is like his blood pressure is 130/80. So it is in the normal range. So he is just having a stable tachycardia.
Stable tachycardia. So whenever you have a tachycardia, what we have said, we have to differentiate whether it is a narrow QRS tachycardia or wide QRS tachycardia. That is ECG wise. The next thing what you have to do is whether the patient is stable or unstable. Can you just tell what are the signs of instability?
Patient coming with complaints of chest pain, patient in hypotension, patient having features of shock, patient with altered mentation because of the event, and patient having any syncopal episodes. And, then also features of heart failure.
Any organ perfusion that is affected, like altered sensorium, chest pain, heart failure, hypotension, these are the signs of instability. This patient doesn't have anything. He just has tachycardia, some palpitation. So that is only his complaint. So he is hemodynamically stable. So again we have taken the ECG.
So it is a narrow complex tachyarrhythmia. So it is a stable narrow complex tachyarrhythmia.
So when you say narrow complex, you have to take an ECG or you have to take a rhythm strip like this and see what is the size of the QRS complex. The QRS complex is less than 3 for an adult patient, we will call it as narrow QRS. If it is more than 3, we will call it as wide QRS. Narrow QRS tachycardia, here we are having a narrow QRS stable tachycardia, otherwise what we can call is an supraventricular tachycardia. It can be a supraventricular tachycardia. So how will you go about for this patient?
So it is a regular narrow complex tachyarrhythmia. We can go ahead with the first vagal maneuvers, that is a carotid sinus massage.
Before that you want to do anything?
Basically in circulation part, another thing is we have to secure a IV line.
Okay.
2 IV lines should be secured.
Okay. Since you are seeing an SVT, what will be your preferred area where to put your IV line?
Ideally the cubital area should be preferred here because we are going for adenosine, maybe a drug we will have to administer.
Okay.
So we'll have to go for a large bore IV cannula maybe in the cubital area.
So the drug of choice for your SVT is adenosine. That is a drug, and the problem with adenosine, it has got a very short half-life. So you want to give a drug that is the drug should reach much faster to the heart. So you can prefer a cubital vein so that the drug will reach much more faster, and after giving the drug you can give 10 ml of saline flush and you can raise the arm so that the drug will reach much faster to the heart. Before you going into a drug, we have some maneuvers like carotid sinus massage. That is a carotid massage what we can do so that we can decrease the heart rate. So we can just can you just elaborate how to do the carotid sinus massage?
So carotid sinus massage is like a vagal manner that we are doing. Before doing the carotid massage, there are like some steps we have to take. So one thing is like we have to check for the presence of any carotid bruit, because if there is a carotid bruit, there is chance of a thrombosis or a occlusion, and if you are doing a massage, it will lead to further the embolization and all those complications. So we have to auscultate with our stethoscope and we have to check for the presence of any carotid bruit.
So we all know that the carotid sinus is located just lateral to your thyroid cartilage, just below the angle of mandible. So that is the area where you need to auscultate initially to look for any bruit. So that is called as carotid bruit. So if there is no carotid bruit, you can do a carotid sinus massage.
So we auscultated it. There is no carotid bruit. Like actually, we have to auscultate like on both sides. We have to auscultate.
So she's auscultating on the left. Right, we have already auscultated. So both the side there is no carotid bruit. We'll be doing on either side, either of the side, either on the right or either on the left. Any side it is okay.
So after that, like we have to explain to the patient the procedure that we are going to give such a pressure to reduce the heart rate, and we have to continue with the cardiac monitoring, and we have to like we can either go for a continuous pressure or a circulatory movement can be given. So we have to palpate for the carotid sinus, that is at just inferior to the angle of mandible at the level of the thyroid cartilage. We have to give the like palpate for the like pulses, then near that is the carotid sinus, and there we have to give a constant pressure or a circulatory movement for like 3 to not more than 10 seconds.
So that is crucial. One side, after ruling out a carotid bruit, 3 to 10 seconds you have to give a massage, that is called as the carotid sinus massage, not more than 10 seconds. You should not be doing more than 10 seconds. So you can do it in the left or right, whichever is comfortable for you, but you have to make sure that there is no carotid bruit. So usually what will happen, some patient will respond to this carotid sinus massage and the heart rate will decrease and the patient will have some suffocation sort of a feeling. So that you have to explain. You will have some difficulty, so don't worry, and make sure that your crash cart, your drugs like atropine, adrenaline, everything is ready. He can go into a cardiac arrest any point of time. So all these drugs should be made available in your ED. So that is the basic thing that what you have to see. First you can try, if it's a stable supraventricular tachycardia, you can try with your carotid sinus massage. If that fails, then the next option comes the pharmacological cardioversion. That is here in a supraventricular tachycardia, we will go for the drug is adenosine. So adenosine 6 mg IV is the first dose to be given. It should be given as a rapid bolus followed by a 20 ml NS flush, and we'll have to lift the upper arm because of the short half-life. So the first drug of choice is your adenosine. The dose is 6 mg. You have to give us a rapid push in the cubital. So we have to ask our team to make a vein in the Drona, put a line in the cubital fossa. So that has to be made mandatory, and you have to tell him clearly that 10 to 20 ml of saline flush has to be delivered and the limb should be raised. Drona, we are going to give adenosine. So we have to give the drug faster, and you have to give 20 ml of saline flush, and also you have to raise the arm.
So we can use a 3-way connector. We will load the adenosine to one way, the flush to one way. Immediately after giving adenosine, we can give the flush through the other way.
Line. So that is first stage, and that is adenosine. Suppose you have given adenosine 6 mg, it failed.
We can again go for a 12 mg, the next
12 mg. So maximum you can give 6 mg or 12 mg. If still it fails, what are the other options that you have?
Then we can go for like agents like a beta blocker or a calcium channel blocker can be attempted.
Then or amiodarone, drugs like amiodarone also can be tried. Suppose this patient is stable, what we have mentioned. Suppose this is an unstable tachycardia. Suppose there is a hypotension. So what will you do at that point?
So if the patient develops signs of instability, then we will go for a DC cardioversion. That is the treatment for a unstable tachyarrhythmia. So for a DC cardioversion, it is a synchronized DC cardioversion. So it is like a painful procedure, and it is like a very significant procedure. So we will have to go for certain checklist things are to be done. So first thing is we will have to get the consent from the patient and the bystander. We have to explain the procedure, that it is a painful procedure, and there is a complication that the patient may go into a cardiac arrest, and there is like a chance of the patient developing maybe a stroke of some LA clot or something is there. There is chance of the patient going into having a stroke
stroke is also to be explained. And you have to give
Burns,
procedural
pain,
sedation.
everything
Need to be explained. So that is regarding your narrow complex tachycardia. So what we have discussed here is a narrow complex tachycardia, that is SVT. We have shown a case scenario of a stable SVT. So stable SVT, the treatment is pretty simple. There is no evidence of instability. So what you have to do, just look for the carotid bruit. You know carotid bruit, start on carotid sinus massage. Then if it fails, drugs like adenosine is the drug of choice. 6 mg. Again, you can repeat one more dose of adenosine. That is, next you can double the dose, that is 12 mg. If it again fails, you have other pharmacological agents like beta blockers or calcium channel blockers, or even a broad spectrum agent like an amiodarone can also be tried. So this is in a nutshell regarding for a stable. Now, once we discuss unstable, that is the patient is having hypotension, hypoxia or anything, the treatment of choice is, we have discussed regarding defibrillation. In that time, I have said regarding cardioversion. So, cardioversion is the time when we use for an arrhythmia when it is unstable, but the patient is not in cardiac arrest. So, like in this scenario, there is hypotension with narrow complex tachycardia, you can use cardioversion. There are certain things that you need to remember. Cardioversion, you need to do the procedural sedation as he has mentioned, and you have to take a proper consent, and there is a chance of burns and all. So, we need to start for an SVT, we can give like 50 to 100 joules of energy, and you need to see how the patient is improving. And one thing, there is one button called a synchronized button in the defibrillator. You have to make sure that you are pressing that synchronized button on when you are doing a DC cardioversion. So we have discussed now regarding a stable SVT, and also briefly we have touched upon an unstable SVT. I hope this was useful for you. Thank you. Thank you.